Dear members and guests, I am very grateful for Professor Xiaolong Qi for this invitation, and it's my great honor to talk about the current guideline for hepatic encephalopathy and future questions. I am Yoshiki Ueno from Yamagata, Japan. In this year, the Japanese Society of Hepatology and Japanese Society of Gastroenterology has a co-laboratory making guidelines for hepatic liver cirrhosis. We have issued this guideline 2010 for the first time and 2015 for the second edition. And this 2020, both society has collaboratively worked for publishing the revision of this liver cirrhosis clinical guidelines. And this guideline committee was led by Professor Yoshiji from Nara Medical University and other members, including me. The content of clinical practice guideline liver cirrhosis is a concept, diagnosis, treatment, and complication of liver cirrhosis, prognosis, and finally, transplantations. And in these revisions, we are including DAA for treating viral hepatitis and of course, description of NASH. And complication of liver cirrhosis, sarcopenia, muscle cramp, pruritus, hepatoproteinuria syndrome, pulmonary hypertension, and vitamin D deficiency, and alcoholic harm reduction are also included. And we have put some classification of evidences. First, qualities of evidences from A, high grade, to D, very low. Description is written here. Also, we describe the classification of recommendation from strong to weak. Strong recommendation to act, strong recommendation not to act, to suggest to act, or suggest not to act. There are some key features in this clinical guideline update. The content should be in accordance with 2019 Clinical Guide for Chronic Hepatitis and Liver Cirrhosis by JSH. Clinical questions will be categorized into one, basic question, second, clinical question, and third, future research questions. Third, use figure and table from other overseas clinical guidelines such as ESRO and ASLD, which may be applicable for Japanese clinicians. Also, we pay attention to establish the standard of description of pathogenesis, which may contribute for future study planning. And after publication of the guideline, the annual review will be performed until next revision, which is scheduled 2025. This is the most famous ASLD and ESL clinical practice guidelines for hepatic encephalopathy. In 2016, JSG guideline has been published in Journal of Gastroenterology, Evidence-Based Clinical Practice Guideline for Liver Cirrhosis. This guideline was led by Professor Fukui at Nara Medical University. Future research question includes lack of evidence, but we try to explain the current understanding toward future important questions. For example, future research question 2.2 is there any treatment option other than prohibition for alcoholic LC? And statement is alcohol harm reduction has been proposed, although long-term effects for cirrhotic patients can be determined in future studies, like this. Then let's move into the hepatic encephalopathy. This cartoon summarizes the mechanism of hepatic encephalopathy or increased blood ammonia levels. Liver urea cycle has been deeply involved in this ammonia productions, and carnitine and zinc are involved in this urea cycle. Of course, the source of nitrogen could be observed from the gut. So, theoretically, non-absorbable disaccharides and antibiotics have been very influential about this process. And lastly, brain and muscle also target organs for this ammonia metabolism. All of these are believed to be involved in the elevated blood level of ammonia. Some of the basic questions already obtained clinical consensus has been moved to the basic clinical questions. For hepatic encephalopathy, one question is moved to basic questions. Now, that one is non-absorbable disaccharide effective for HE? And statement is, since non-absorbable disaccharide is effective in improving symptoms and clinical indicators of HE, its administration is recommended as a first-line treatment for HE. So, since this is already established idea and practice, we don't put recommendation grade or evidence level because this is obvious. One of the issues is about the criteria of coma grade of hepatic encephalopathy. As described in ASLD and EASL guideline, West Haven criteria and Asian description are the most widely used, which are introduced in these tables. However, for a long time, for Japanese gastroenterologists or hepatologists, eNOS criteria has been widely used. But now we need to unify this criteria according to the WHC or Asian. The most important difference is eNOS criteria has only 1, 2, 3, and 4 and 5 this. So from future studies, we need to accordance with this coma grade to WHC or Asian. Also, as like ASD guidelines, we need to classify the HE according to its underlying liver diseases. A is resulting from acute liver failure, and B is resulting predominantly from portal systemic bypass or shunting, and C is resulting from cirrhosis. For hepatic encephalopathy in Asia, most of the patients have this kind of type C encephalopathy. For the time saving, I put this 4 of the clinical questions from the revised clinical practice guidelines. 13 is, should combat HE be treated? 14 is no absorbable antibiotic effective for HE. 15 is zinc supplementation effective for HE. 16 is carnitine supplementation effective for HE. These 4 are almost answered, and 2 of them are still need to be examined in future. As for the antibiotics, the previous guideline, we don't recommend strongly about this use of non-absorbable antibiotics, namely rifaximin. Since at that time, phase 3 clinical trials has been underway in Japanese populations, so we don't have actual options for use the rifaximin in clinical settings. However, now the Japanese FDA approved the use of rifaximin in cirrhotic patients. We put the recommendation level to 1, very strong, and evidence put A. So in these revisions, non-absorbable antibiotics is effective for both first episode and recurrent HE. It should be regarded as a fundamental treatment option for HE. This is the example of the evidence which get impact for CQ315. This is the Japanese study from the clinical trials, phase 2 and 3. And this is the review article about the overt hepatic encephalopathy by Dr. Muller et al. And this is also the meta-analysis, systematic analysis about the rifaximin treatment. And systematic review is here published in the APNT, or favor for the use of rifaximin for the treatment of hepatic encephalopathy. The next question is, should covert HB should be treated? Covert HE is very difficult to diagnose. As a result, there are so many heterogeneous populations about the clinical study. Actually, the diagnosis of HE, covert HE, is very, very difficult. Most of them you need to be very experienced hepatologist or psychiatrist. And unfortunately, most of the diagnostic methods is very subjective. Otherwise, you need very special apparatus or software to diagnose very early covert hepatic encephalopathy or minimal hepatic encephalopathy. So most of other guidelines, our statement is we suggest to treat to covert HE if the patient has high risk factors such as worsening background hepatic reserve or existence of other symptoms of hepatic decompensation. Of course, since the evidence is not strong, the recommendation strength is 2, and evidence level is B. So this could be answered by future research. In this division, there are some changes about the carringing. In previous guidelines, the recommendation strength was not descriptive. However, in these revisions, we put the recommendation strength as 2 weeks recommendation and put the evidence level as B. Since carringin deficiency is frequently associated with cirrhotic patients, carringin supplementation is suggested for HE patients with carringin deficiency. Then the next question comes, what is carringin deficiency? Major cause of carringin deficiency indicated in these tables. The carringin deficiency is categorized as primary and secondary. And as you will see here, the liver cirrhosis is one of the conditions, acquired medical conditions for demonstrate exhibit carringin deficiency. One of the cautions which are listed in Japanese version of this homepage, carringin deficiency in liver disease could be due to both decreased production and decreased dietary intake. Unfortunately, blood-free carringin levels do not always demonstrate low values, since intracellular pool of carringin could be released from inflamed hepatocyte. So it is not reliable to the diagnostic tools. So Diagnosis of carotene deficiency in patients with liver disease cannot be done with a measurement of blood level. It can be done only by the clinical judgment from physical examination, clinical symptoms, and laboratory findings. Patients with advanced liver disease need to be considered as carotene deficiency in liver, muscles, and mitochondrial in cellular levels. However, there are growing evidence for the effectiveness of carotene for treating hepatic encephalopathies. In previous editions, there are very limited research to this study. But after 2015, there are several studies describing the effectiveness or usefulness of carotene for treating HE, which are some of them are indicated here. I would like to introduce some of the most demonstrable results. This study demonstrates the long-term 3-month usefulness of decreasing blood ammonia levels after carotene supplementation. As you see here, the administration of carotene significantly reduced the level of blood ammonia levels. Also, other researchers demonstrated the high-dose carotene are more attentive to decrease the blood ammonia levels compared to the low dose levels. So, taken together, our updated clinical guideline recommend to think about the clinical supplementation in a suitable patient who are supposed to have carotene deficiency. However, there are still some open questions. The diagnosis of minimal hepatic encephalopathy and covert hepatic encephalopathy. We need very objective and reproducible and quantified method. So maybe a computer software or application could be helpful. And also, we need to demonstrate the treatment effect on individuals and society. That means, should we treat all covert encephalopathy? Because some reports study demonstrate even in covert patient with HE, covert HE patient has driving disabilities, which could be potentially harmful to the society. And of course, there are no head-to-head comparison about the first-line treatment, especially rifaximin. Now, rifaximin is approved in so many countries, including Asian countries. However, there are very limited studies comparing the effect of rifaximin to non-absorbable disaccharides such as lactulose or lactitol. Of course, treatment duration is still debatable. And how do we need to treat those patients? And long-term effectiveness, cost, safety, and adherence and quality of life effects should be evaluated in prospective manner. And so, as a result, finally, we need very good and high-quality global multi-center studies about the hepatic encephalopathy, especially for covert hepatic encephalopathy. Lastly, my words. I'd like to thank all the organizers and hoping organizers could propose future global multi-center studies about treating hepatic encephalopathy. Thank you.
Okay, we are going to try to give a talk for APASL. My name is Don Rocky. I'm coming to you from Charleston, South Carolina, the Medical University of South Carolina. The background is my backyard, and you can see a container ship coming in through the harbor. Now let's see if I can get this to share my screen and get the talk started. Okay, so that's my Zoom meeting. Here is my talk. Let's give this a shot. All right, this is downtown Charleston. So it's a real pleasure to talk with you this afternoon and tell you about the molecular basis of portal hypertension. I'd like to start by thanking Dr. Qi for the invitation to join you virtually, and I hope that you all are safe and doing well. I'm going to try to keep this to 15 minutes, so this should be fairly focused. These are my disclosures. We receive research funding from a number of entities, including the NIH. I have done some consulting for Merck, and I don't own any stock or I don't participate in speakers bureaus. So our learning objectives today will be to recognize that portal hypertension develops in chronic liver disease as a result of increased resistance to blood flow, as well as increased blood flow to the liver. Appreciate that hepatic stellate cells and endothelial cells, as well as various vasoactive mediators, are critical in the pathogenesis of portal hypertension. And I think that the basic biology here will have implications for novel therapies. I'm gonna spend a minute talking about portal hypertension and present a patient, and then we'll talk briefly about both hepatic stellate cells and endothelial cells, as well as give you a story about two vascular mediators, and then I'll just spend a minute summing up. So this is a patient that we have seen, a 57-year-old gentleman with a past history remarkable for type 2 diabetes mellitus. For 18 years, referred for evaluation of abnormal liver tests. He also has essential hypertension, so he has the metabolic syndrome. His physical examination is unremarkable. He actually had a normal BMI or slightly elevated BMI. You can see his liver tests here are elevated. His bilirubin and INR are normal. Albumin is 4, platelets 155. An ultrasound that was normal, and after being followed for a while, he underwent transjugular liver biopsy and HBPG measurement. So here is his biopsy, and you can see that this is a cirrhotic liver. This is a Masson trichrome, and I think we would all agree that there are nodules here, and this is advanced fibrosis. He had an HBPG at that time of 8. He underwent an endoscopy, did not show any varices. He was told to begin diet and exercise, this was met with somewhat borderline success. He clinically feels well. The challenge when you see this gentleman is, you know, this gentleman has underlying liver disease and he has portal hypertension. He does not have clinically significant portal hypertension, has no evidence of complications at this time, but it is likely that this is going to progress. So when we think about portal hypertension, I would encourage you to think about this as a vascular disease. There are alterations in many, many vascular beds in the cirrhotic patient. The liver and the kidney are characterized by intense vasoconstriction, whereas the splanchnic vasculature, the brain, the lungs, and the peripheral vasculature are typified by vasorelaxation. And the pathophysiology is quite different for all of these beds, and in fact, very interesting. We're going to focus on the liver today. So when we think about the pathogenesis of portal hypertension, and here I'm talking about the intrahepatic component of portal hypertension. We think about components of both modulable and fixed elements that lead to an increase in intrahepatic resistance. The modulable components are the cellular elements, which we're going to talk about shortly. I would also suggest that perhaps at least early in many forms of chronic liver disease, there may be actually dynamic changes in the organ at an organ level that include contraction, and this has been demonstrated by a number of investigators. When we have very late disease, we have extensive scar formation, nodules, and extensive bridging, and at this level, there may not be as much dynamism in the intrahepatic resistance as at earlier levels. And I would emphasize that in early portal hypertension where increased resistance occurs, this is likely to be modulable, whereas in late portal hypertension where we get a reflex increase in blood flow, this is probably not going to be able to be treated with therapy targeted in the liver, but rather this is where beta blockers work to reduce flow. And again, remember the portal pressure is a factor of flow and resistance as indicated by the hydraulic equivalent of Ohm's law. So when we think about intrahepatic blood flow, we think about the sinusoid. This is a cartoon depicting the sinusoid, and you can see here, this is the sinusoidal endothelium. It is encircled and wrapped by these remarkable cells that you all know as hepatic stellate cells. Work from Japan by Waki and Sato has done some elegant experiments showing that hepatic stellate cells encircle and wrap sinusoids, and you can see here a sinusoid here and this is silver stain, and these are hepatic stellate cells encircling and enwrapping these sinusoids. So you can imagine that these stellate cells could control sinusoidal blood flow. And so when I began working in the laboratory, we tested the idea that stellate cells could be contractile and began examining contractile and or vasoactive agents. And so we've studied multiple of these agents. We focused initially on agents that lead to contraction, including endothelin and others, as well as those that stimulate relaxation. In our efforts, we've studied, again, multiple of these agents. And the thing that stimulates stellate cell contraction most prominently are the family of endothelins. And I'm not going to spend a lot of time talking about the endothelins. This work has all been published. Rather, I'm going to summarize and tell you the endothelin story. And that is that in the normal liver, endothelin is made predominantly by sinusoidal endothelial cells. It's made as a precursor. It gets cleaved to big endothelin and then the mature 21 amino acid peptide. Peptide is released. It probably acts primarily in an autocrine fashion on endothelial cells to stimulate the endothelin B receptor. In hepatic stellate cells, there are some endothelin receptors in normal liver, not a lot, but there are some, and these are both A and B receptors. They probably stimulate stellate cell contraction at some level in the normal liver. In the injured liver, however, things are quite different. And what happens here is that endothelin production by the endothelial cell actually is dramatically decreased, which likely reduces the activation of the B receptor in endothelial cells. But there is a dramatic upregulation of endothelin-1 production by hepatic stellate cells. And at the same time, there is a dramatic upregulation of the receptor, particularly the endothelin B receptor. And this then this increased production of endothelin acts in an autocrine fashion on hepatic stellate cells to stimulate their contraction. And you can see that they can contract in the sinusoid and affect sinusoidal blood flow. I'm not going to talk about the mechanisms of regulation of endothelin in stellate cells. This has also been published, but suffice it to say that there are complex and very interesting mechanisms of regulation of endothelin production in hepatic stellate cells. I'm going to spend most of the time this afternoon talking about nitric oxide. And that is because nitric oxide is the compound that is the most prominent relaxing factor for hepatic stellate cells. We have studied a number of these other agents. In our hands, they are not quite as potent as nitric oxide. And therefore, we've really focused on the NO pathway. To get us all on the same page, nitric oxide is made by one of three isoforms of nitric oxide synthase, shown here, the neuronal, the inducible, and the endothelial isoforms. You can see that they're highly, highly homologous in terms of their overall structure with different enzymatic and binding areas. The endothelial form is slightly unique in that it is myristylated and often found near the cell membrane. The endothelial and neuronal forms are thought to be constitutively active, whereas the inducible form is induced in virtually all cells by interferon and cytokines and things that are produced in the inflammatory condition. We have been very interested in blood flow in the liver as well. This is the edge of a pseudo-colored mouse liver, and you can see here the capsule. This is a terminal hepatic venule. These are sinusoids, and we have shown, this is work that Claire Edwards did, we have shown very nicely that there are dynamic changes in the sinusoid in response to vasoconstrictors like endothelin, and then exposure to vasodilators like nitric oxide. And you can see here, I think these sinusoids here are constricted, and here they're relaxed. We can measure this morphometrically, and you can see here very nicely that when we expose the liver to puro NO, an NO donor, sinusoids dilate over time. So we became interested in the nitric oxide story in liver and hypothesized that NO would be produced by sinusoidal endothelial cells, and lo and behold, it certainly was. We were the first to clone eNOS from endothelial cells. But interestingly, the mRNA and protein levels were unchanged after injury. However, the level of the enzyme activity was dramatically reduced in the cirrhotic liver. And you can see here very nicely that there is a several-fold reduction in eNOS function in endothelial cells isolated from cirrhotic livers compared to normal livers. So very clear that while there's no change in the protein level, there is a change in eNOS function, which suggests that there is some post-translational modification of the enzyme. And in fact, that is how eNOS function is regulated, not by expression, but by post-translational regulation. And this is a cartoon that highlights many of the pathways that have been invoked in eNOS function. It has been shown elegantly by Bill Sessa's group and Tom Michel's group that eNOS is post-translationally modified by AKT, HSP90, calcium calmodulin, and all of these various players have, caveolin-1, have effect on eNOS phosphorylation and eNOS function. We got interested in this because, as I showed you, that endothelial cells have a reduced expression or reduced production of NO. And we hypothesized that because the signaling pathway is through the endothelin B receptor, that this could be a G protein coupled mechanism. And therefore, this is a cartoon that shows endothelin B, GPCR, signaling to G proteins, then to PI3 kinase and AKT, which is very high upstream in the signaling pathway. We hypothesized that there would be some process for desensitization and reduction of the functional activity of the enzyme. And we got interested in a protein known as GRK2, which had been shown by Bob Lefkowitz's lab and Richard Premont to desensitize GPCR signaling. And we hypothesized that this could be at the level of AKT, and that is certainly ultimately what we found. So what we did here, this is an experiment over on the right side where we overexpressed GRK2. This is a carboxy terminus, the active part of this, and then measured phosphorylation of AKT, and you can see phospho-AKT is reduced, and it indeed blocks endothelin stimulated phosphorylation of AKT. It also reduces nitric oxide production. So down here you can see that endothelin stimulates NO, and then you can block that with GRK2. It turns out that GRK2 is also regulated in the liver after liver injury. So this is an experiment where we perform bile duct ligation and then simply measure GRK2 over time, and you can see very clearly that GRK2 is upregulated. And so the question becomes, is this physiologically important? And the answer is yes. So it turns out the GRK2 knockout mouse is a lethal mutation. So we took GRK2 heterozygotes, and you can see here that there is GRK2, but there is a reduction. The GRK2 hets have increased expression of phospho-AKT, and lo and behold, they have a reduction in portal pressure after liver injury. So when you do, this is in mouse, when you do bile duct ligation after liver injury, you get an increase in portal pressure, and then this is reduced in these heterozygous mice. So the summary of the GRK2 signaling is that in the normal liver, you have endothelin stimulating the B receptor, activating G proteins, stimulating AKT, it's phosphorylated, leads to eNOS phosphorylation and NO production. However, in the injured liver, you have upregulation of GRK2, which then leads to reduced phosphorylation of AKT and reduced phosphorylation of eNOS. Now, in the most recent work that we've done, we have gotten interested in another signaling partner in the GPCR signaling cascade, and that is beta-arrestin. So the arrestins are a family of 4 cytosolic GPCRs, GPCR binding proteins that regulate a wide range of functions. Beta-arrestin 2 is a 406 amino acid protein. It was initially described actually as an inhibitor of GPCR signaling, but is now known to serve as a scaffold for multiple different signaling pathways. And this is a cartoon from Begnato and al. That just shows some of these various signaling proteins or signaling pathways. So we became interested and asked whether this could be a player in the eNOS cascade, and this work was actually just now published. And what you can see here is that beta-arrestin 2 is downregulated in the injured liver. So, and this can be CCL4 or bile duct ligation. You can see here, this is carbon tetrachloride immunohistochemistry. Here's beta-arrestin 2 in the normal liver. Here it is in the injured liver, and you can see there's reduced expression. It is expressed predominantly in endothelial cells. You can see here is co-localization of eNOS and beta-arrestin. So eNOS is only found in endothelial cells in the liver, and you can see it pretty much co-localizes. And you can see that there's a reduction in beta-arrestin 2 expression in endothelial cells in these livers. These are the data quantitated over here and over here. And then this just shows the relative proportion of beta-arrestin 2 and eNOS. Okay, so in some elegant experiments using high-resolution microscopy, we have examined the movement of beta-arrestin 2 and eNOS after liver injury. So this is an edge of an endothelial cell that you can see here, and this is labeled with eNOS. This is labeled with beta-arrestin 2, and then this is co-labeled. And you can see here that there's very nice co-localization. That would be predominantly white of the beta-arrestin 2 and eNOS. And you can see here is a XZ section where there is intense co-labeling of beta-arrestin 2 and eNOS. In the injured liver, there's eNOS itself is really pretty much unchanged in expression, as I've already shown you, but beta-arrestin 2 is down. And you can see here that there's less co-labeling of beta-arrestin 2 and eNOS. In stimulated cells, there is beautiful movement of eNOS and beta-arrestin 2. So here is normal liver, and here's co-localization of our co-labeling with eNOS and beta-arrestin. Here's XY, XZ sections. Here we can see that there is, after stimulation, there's nice co-localization, and you can see here that that beta-arrestin and eNOS seem to move to the cell membrane. In the injured livers, in contrast, you can see eNOS here is scattered. There is less beta-arrestin, as I've already shown you. And after stimulation with eNOS, with endothelin-1, there is a little bit more co-localization, but not impressive. So this suggests that not only in injured liver is there a reduction in beta-arrestin expression, but there may be other changes that lead to less co-localization of these two proteins, which is an area that we're actively studying right now. The other thing that is very important here is that you can actually rescue NO production. So this is in the normal situation. You can see there's an upregulation of NO production when you overexpress an adenovirus, when you overexpress beta-arrestin 2 with an adenovirus expressing beta-arrestin 2. Nitrite production is also increased. I'm not exactly sure why my slides keep advancing mysteriously, but in the injured endothelial cell, you can see that there's an increase in NO production with this adenovirus expressing beta-arrestin 2. And in addition, you can rescue portal hypertension. So if you overexpress an adenovirus with beta-arrestin 2, you can reduce portal pressure in the injured liver. So the summary is that beta-arrestin 2 is regulated in liver injury. It stimulates, and I haven't shown you this data, there's another protein that appears to be involved, and that's known as GIT, but it stimulates activation of eNOS, and therefore beta-arrestin 2 is likely another target of for potential treatment. Again, we would like to somehow rescue beta-arrestin 2 function in the injured endothelial cell. So in the big picture, just finishing the story, in the normal liver, you have a balance between vasoconstrictors and vasodilators. Again, this is at the sinusoidal level. and you have normal sinusoidal resistance. Whereas in the injured liver, there is an imbalance between the vasoconstrictors and dilators. I've shown you there's an increase in endothelin, there's a decrease in nitric oxide, and this leads to an increase in sinusoidal resistance. And this is almost certainly most prominent early in liver disease, you know, when you've got portal pressure in that 4 to 8 to perhaps 10 range. And I think this suggests that suggests a pathway to treatment, and that would be to replace the vasodilators or block the vasoconstrictors. I do think that treatment of fibrosis likely is important. As you treat fibrosis, you're likely to lead to stellate cell reversion of their activation. You may also improve the function of endothelial cells. I also believe that correction of the defect in NO production in sinusoidal endothelial cells is likely to be a viable therapeutic option. So with that, I will conclude and thank the people in the laboratory who have done the work. The ones highlighted in blue have been active in the primarily the endothelin story. Songling Liu has done virtually all of the work in the eNOS story, and we've been very lucky to have collaborators here at MUSC, Lou Luttrell, and at Case Western, Richard Fremont. So with that, I will end. I guess there's no way to answer questions, but if you would like to ask anything about this, feel free to send me a email, and I would be more than happy to answer anything that I can. Again, thank you very much, and I hope the meeting is fabulous.
My name is Maura Hilscher. I'm an assistant professor of medicine at the Mayo Clinic in Rochester, Minnesota, and I'll be speaking about the role of mechanocrine signals and immunothrombogenesis in the pathophysiology of portal hypertension. Portal hypertension is a common final pathway of multiple forms of chronic liver disease. It leads to several complications, including ascites, varices, and hepatic encephalopathy, and thereby accounts for significant morbidity and mortality among patients with liver disease. However, there are few effective therapies available to treat portal hypertension. The main determinants of portal pressure are vascular resistance and blood flow. While the pathogenesis of portal hypertension varies according to the etiology, portal hypertension generally results from an increase in intrahepatic resistance or blood flow in the portal venous system. Several factors may culminate in increased intrahepatic resistance, including scar tissue and regenerative nodules in the setting of cirrhosis. Capillarization of the sinusoids and swelling of cells, including hepatocytes and Kupffer cells, also increase intrahepatic resistance. Chronic hepatocellular injury leads to activation of hepatic stellate cells, resulting in collagen production and sinusoidal constriction. In addition to permanent architectural distortion of the liver parenchyma, increased vascular resistance occurs in cirrhosis as a result of exaggerated production of vasoconstrictors and deficient release of vasodilators. This constitutes a dynamic and potentially reversible component that accounts for 30% of the total increase in intrahepatic vascular resistance. Cirrhosis is characterized by splanchnic vasodilation, which increases portal blood flow and therefore portal pressure. Over time, this leads to remodeling of the splanchnic vasculature, which contributes to intrahepatic resistance. Reduction of portal pressure may decrease the incidence of complications associated with portal hypertension and potentially improve survival. Unfortunately, currently available therapeutic options have limited efficacy or carry substantial risks. I will review a few potential therapeutic targets here. Portosystemic shunting procedures, including surgical shunts and tips, are effective in reducing portal pressure. However, these are invasive procedures which have risks, including that of hepatic encephalopathy. Several pharmacologic therapies have been studied in an attempt to alleviate sinusoidal constriction. These include angiotensin receptor blockers, which inhibit contraction of hepatic stellate cells. However, the use of these medications in patients with liver disease increases the risk of renal dysfunction. As noted earlier, intrahepatic vasoconstriction constitutes a potentially reversible component of portal hypertension and is an attractive therapeutic target. Carvedilol is a non-selective beta blocker with anti-alpha-1 adrenergic activity, which reduces intrahepatic vascular resistance. However, it can lead to significant drops in mean arterial blood pressure, which may be poorly tolerated by patients with cirrhosis. Studies have found that statins increase nitric oxide release in the liver and thereby decrease hepatic sinusoidal resistance. Thus far, studies have not found an effect on the prevention of variceal bleeding. However, simvastatin may confer a survival benefit in patients with Child-Pugh class A or B cirrhosis, which requires further investigation. Finally, non-selective beta blockers such as nadolol and propranolol are among the most common therapies used in the management of portal hypertension. Beta blockers reduce portal venous inflow by inhibiting beta-2-induced splanchnic vasodilation. As I will highlight in the following slides, our studies suggest that inhibition of neutrophil function and microvascular sinusoidal thrombosis constitute novel therapeutic targets in the management of portal hypertension. We have studied portal hypertension in the setting of congestive hepatopathy. This occurs in conditions such as heart failure and congenital heart disease, which prevent the effective circulation of blood by the heart and thereby lead to congestion of the liver. This phenomenon is nowadays more frequently observed owing to an increasing prevalence of chronic heart failure in an aging population. Seen here are contrast-enhanced T1-weighted MRI images depicting the heterogeneous enhancement of the liver parenchyma, which is characteristic of congestive hepatopathy. The panel on the left was obtained in the portal venous phase, while the panel on the right was obtained with a 3-minute delay. Fontan-associated liver disease is a form of congestive hepatopathy which occurs in those patients with single ventricle congenital heart defects who have undergone a Fontan procedure. The Fontan operation induces a state of systemic venous hypertension. As a result, the liver in the Fontan physiology is exposed to higher hepatic afterload and passive venous congestion. Patients with a Fontan circulation are at risk for long-term complications related to passive venous congestion of the liver, including cirrhosis and portal hypertension. In order to study the pathophysiology of portal hypertension in the setting of congestive hepatopathy, we developed a murine model which entails partial ligation of the suprahepatic inferior vena cava, as seen here on the left. Since autopsies from patients with congestive hepatopathy have reported sinusoidal thrombosis, we examined the role of microvascular sinusoidal thrombosis in the pathophysiology of congestive hepatopathy. Immunofluorescence studies revealed that fibrin was significantly increased in the liver after IVC ligation compared to controls, and sinusoidal fibrin deposits were spatially associated with alpha smooth muscle actin. Alpha smooth muscle actin is a marker of hepatic stellate cell activation, and thus this result suggests a potential role of thrombosis in the fibrogenic response. We found significant increases in portal pressure as early as 2 weeks after the IVC ligation procedure, as measured by direct cannulation of the portal vein. Onset of portal hypertension preceded the development of significant fibrosis, as measured by hydroxyproline. We then utilized MR elastography to study our IVC ligation model of congestive hepatopathy at 2, 4, and 6-week time points. MR elastography is a newer imaging technology which measures tissue stiffness and which is increasingly used to assess several forms of liver injury, including hepatic fibrosis, congestion, and portal hypertension. We found that liver stiffness correlates with portal pressure, even in the absence of fibrosis at the earlier time points. To confirm the role of thrombosis in the pathophysiology of congestive hepatopathy, mice were anticoagulated with warfarin. As demonstrated by immunofluorescence, warfarin-treated animals showed a significant reduction in both fibrin and alpha smooth muscle actin intensity compared to mice which were not treated with warfarin. Serious red staining confirmed a significant decrease in fibrosis burden in mice treated with warfarin. Treatment with warfarin also led to a significant reduction in portal pressures 6 weeks after IVC ligation. Having identified a role for sinusoidal thrombosis in the pathophysiology of fibrosis and portal hypertension and congestive hepatopathy, we next examined the role of mechanical forces imposed by congestion on liver sinusoidal endothelial cells, which are the primary sensors of disturbances in the hepatic circulation. We hypothesized that stretch from passive congestion activates mechanosensitive pathways in endothelial cells, which promote microvascular thrombosis, fibrosis, and portal hypertension. To begin our study, we isolated primary sinusoidal endothelial cells from mice and subjected them to cyclic biaxial stretch using a flex cell device as shown. We imposed stretch at an intensity and a frequency which were intended to mimic the force experienced by sinusoidal endothelial cells during congestive hepatopathy. We then performed microarray screening of genes which impact endothelial cell function. This revealed that cyclic stretch induced transcriptional upregulation of a number of cytokines which impact inflammatory cell chemotaxis, including CXCL1. We confirmed the increase in CXCL1 by quantitative PCR, and ELISA analysis confirmed increased secretion of CXCL1 by liver sinusoidal endothelial cells subjected to cyclic stretch. These findings suggest that liver sinusoidal endothelial cells subjected to stretch generate chemotactic signals which can induce the infiltration of immune cells, including neutrophils. Our finding that liver sinusoidal endothelial cells subjected to stretch release CXCL1, which is a neutrophil chemotactic cytokine, piqued our interest in neutrophil extracellular traps, or NETs. NETs are a recently described phenomenon which consists of a scaffold of chromatin fibers secreted by neutrophils. These chromatin fibers are extruded by a neutrophil and bind to histones and granular proteins, such as myeloperoxidase and neutrophil elastase. A typical NET structure is visualized here by electron microscopy encapsulating a bacterium. Although their primary function is in immune defense, NETs play a pivotal role in thrombogenesis in the setting of the antiphospholipid syndrome, cancer-associated thrombosis, and atherothrombosis. Given their prominent role in promoting thrombosis formation, we hypothesized that NETs could contribute to microvascular thrombosis in congestive hepatopathy. To directly examine the role of neutrophils in congestive hepatopathy in vivo, we performed intravital imaging 24 hours after IVC ligation and sham procedures. Neutrophils are labeled with a red conjugated antibody and platelets with blue conjugated antibody. Cytox green was used to label extracellular DNA. Intravital microscopy of livers 24 hours after sham procedure revealed normal sinusoidal architecture with sparse neutrophils, which traverse through the sinusoids and then rapidly exit via the hepatic vein. Light green in this image reflects hepatocyte autofluorescence. Visualization of livers 24 hours after IVC ligation revealed significant sinusoidal dilation and vascular accumulation of neutrophils, which aggregate with platelets. These findings suggest that neutrophil stasis within the sinusoids may serve as a nidus of platelet interaction and thrombosis in the setting of congestive hepatopathy. Platelet interaction with activated neutrophils is a potent inducer of NET formation, and NET components have the capability to propagate thrombosis. Having visualized extensive neutrophil platelet aggregation after IVC ligation, we hypothesized that this interaction may promote the formation of NETs, which then propagate thrombosis, fibrosis, and portal hypertension. We utilized combination staining with intravital microscopy to visualize co-localization of 3 key NET components: extracellular DNA in green, histone in red, and neutrophil elastase in blue. Visualization of livers 24 hours after IVC ligation revealed co-localization of these structures within the lining of the sinusoids, which was absent after the sham procedure, indicating that NETs form in the sinusoids in congestive hepatopathy. To further test our hypothesis, liver samples were obtained from patients who had undergone the Fontan procedure in addition to healthy controls. We performed immunostaining, which confirmed that livers from patients with Fontan physiology had increased sinusoidal fibrin that was spatially associated with myeloperoxidase, a neutrophil granular protein, which is a key component of NETs. This suggested that NET formation was driving sinusoidal thrombosis in Fontan patients. The formation of NETs results in the release of double-stranded DNA, which is commonly measured as a marker of NET formation. Serum obtained from Fontan patients at higher levels of circulating double-stranded DNA myeloperoxidase and double-stranded DNA citrullineated histone complexes compare with healthy controls. This confirmed the relevance of our findings in patients with congestive hepatopathy due to the Fontan procedure. To determine the role of net formation on portal hypertension and fibrosis, neutrophil elastase deficient mice were subjected to IVC ligation and sham procedures and then compared to wild-type mice. Neutrophil elastase is a granular protein that is a key component of and driver of net formation. 6 weeks after IVC ligation, elastase deficient mice had significantly lower portal pressures when compared with wild-type mice undergoing IVC ligation. Next, we use immunofluorescence studies to confirm that elastase deficiency attenuates intrahepatic thrombosis. These studies revealed decreased fibrin immunostaining as well as decreased spatial association with collagen. These results suggest that neutrophil elastase deficiency attenuates portal hypertension and fibrosis in the setting of congestive hepatopathy by preventing thrombosis. To corroborate our genetically derived findings, we used the neutrophil elastase inhibitor Civelistat, which was injected subcutaneously 3 times a week after IVC ligation and sham procedures. Civelistat has been previously used safely in both animal and clinical studies, predominantly pulmonary diseases such as bronchopulmonary dysplasia and acute lung injury. Civelistat-treated mice had significantly lower portal pressures 6 weeks after IVC ligation when compared with vehicle-treated mice. Livers from Civelistat-treated mice demonstrated less fibrin formation compared with control mice. Civelistat treatment also decreased sinusoidal myeloperoxidase deposition, suggesting that it successfully disrupts net formation. This revealed the exciting therapeutic potential of net inhibition in modulating portal hypertension. In summary, we found that cyclic stretch imposed by congestion induces the release of CXCL1 by liver sinusoidal endothelial cells. CXCL1 promotes neutrophil chemotaxis, aggregation with platelets, and formation of nets. Nets promote formation of microvascular thrombosis and portal hypertension. We postulate that fibrin physically modulates portal pressure through volume and pressure impact within the sinusoids. This highlights a critical role of nets-induced thrombosis in the pathogenesis of portal hypertension and reveals an exciting therapeutic possibility in the management of portal hypertension. Thank you very much for your attention.
Thank you, Chairman, and ladies and gentlemen. It is my great pleasure and honor to give a talk at APASL conference on portal hypertension. I thank Professor Xiaolong Qi for inviting me to this event. So today I will give a talk on regression of liver fibrosis and reduction of portal hypertension by eradicating controlling infected hepatitis virus. This is the agenda of my talk today. First, I will give a talk on molecular and cellular mechanism of liver fibrosis. Portal hypertension and hepatocellular carcinoma originated basically from the fibrotic and cirrhotic liver. It is important to understand the molecular events underlying liver fibrosis. Inducing regression of liver fibrosis and portal hypertension is a key to improve the prognosis of advanced chronic liver disease patients. Liver is basically consisted of hepatocyte, bile duct cells, and sinusoids, which are composed of endothelial cells, Kupffer cells, pit cells, and stellate cells. Stellate cells are liver-specific pericyte and envelope sinusoidal wall. According to this anatomical situation, contraction of stellate cell narrows diameter of sinusoids. When liver injury takes place, activation of the coagulation cascade triggers inflammatory cell infiltration into the damaged site, and they secrete several cytokines and chemokines. Resident stellate cells respond to the stimuli and become activated and produce basement membrane-like substrata. When liver injury persists, chronic injury triggers perpetuation of stellate cell activation, leading to extracellular matrix accumulation in the liver. Finally, in cirrhosis, activated stellate cell deposit collagen in the space of Dise, leading to the defenestration of sinusoidal endothelial cells and acquire contractile properties that lead to sinusoidal constriction, which is responsible for increased intrahepatic vascular resistance and portal hypertension. So next, I will talk about regression of liver fibrosis, cirrhosis by hepatitis virus control. Cirrhosis was previously considered to be an endpoint of liver disease. However, recent clinical evidence has clearly clarified withdrawal of the injurious agent can allow remodeling of the fibrillar matrix, leading to the attenuation of liver cirrhosis. This slide shows the mechanism by which antifibrotic therapies may lead to fibrosis regression. Here I will mention on number 1 point, disease-specific therapies that control or cure the underlying disease are the effective antifibrotic approach. For instance, hepatitis virus B can be controlled by nucleic acid analogs, and SCB can be eradicated by direct-acting antivirals. This is our case report with HBV infection showing marked improvement of liver fibrosis by entecavir treatment. Before treatment, series red-colored collagen deposited area was 12.3% of the total liver parenchyma. This was markedly reduced to 8.3% at 12 months treatment with entecavir. Accordingly, alpha smooth muscle active positive area indicating the presence of activated stellate cells was markedly reduced. This is a paper from Taiwan demonstrating that 4-year entecavir treatment reduces the cirrhotic events in HBV patients. After propensity swaggering matching, hepatocellular carcinoma development, variceal bleeding, SBP, hepatic encephalopathy, liver-related mortality, and all-cause mortalities are all evidently lowered in entecavir treatment compared to untreated cohorts. This paper clearly indicates HBV control contribute to the prevention of liver fibrosis related and portal hypertension related events. Next, how is the regression of liver fibrosis in SCV infected patients? As shown in the left panel, already in 2000, a study conducted by Japanese group demonstrated that regression of liver fibrosis took place in patients achieving SVR in interferon-treated CHC patients. The Ambrosio reported in 2012 that after 5 years from SVR by interferon, cirrhosis regression was observed in 61% of the patients and collagen content decreased in 89%. Now, SCV infection is treated with direct-acting antivirals DAA therapy. This slide summarizes the efficacy of DAA in a university hospital in more than 1,000 SCV infected patients. SVR12 ratio is about 95.8%, very high. In those patients, serum fibrosis markers such as type 4 collagens, M2-BPGI, and liver stiffness measured by FibroScan were all suppressed in patients treated with DAA. This shows a typical liver histology of HCV-infected 74-year-old patient. So before all treatment, there were numerous green-colored smooth muscle alpha-actin positive activated stellate cells that were estimated to produce extracellular matrix proteins. After the AA treatment, the number of activated stellate cells markedly reduced. This observation further indicates liver fibrosis can be regressed when HCV is eradicated. This review summarizes potential long-term benefit of DAA treatment against HCV infection. As we realize, there are many words: regression, reduction, avoidance, improvement, etc. All taken together, in human liver disease, disease-specific therapies that control or cure the underlying disease can be said the effective anti-fibrotic approach. Then I will move to the next topic, reduction of portal hypertension by hepatitis virus control. The mechanism in the development of portal hypertension in cirrhosis is an increase in vascular resistance to portal flow due to a distorted sinusoidal architecture. However, a subsequent increase in portal venous inflow secondary to splanchnic vasodilatation maintains the portal hypertensive state. In sinusoidal portal hypertension, the sinusoidal communications are blocked by fibrous tissue, resulting in the elevated wedge hepatic venous pressure. The free hepatic venous pressure remains normal, and therefore the HBPG is elevated. HBPG more than 10 mHg is classified as clinically significant portal hypertension. By the way, in our university hospital, we have developed a non-invasive method for HBPG measurement from the peripheral antecubital vein. So please watch the video a little bit. Also, this method has been mentioned in a review article of hepatic venous pressure gradient measurement. No detailed description of this approach has been published. We utilize this method to measure hepatic venous pressure gradient in non-invasive manner for cirrhotic patients. Okay, I return to my topic. As shown in this report, in HCV-infected cirrhotic patients, DA treatment was reported to suppress HBPG. In this report, 8 of 9 patients who had HBPG more than 12 mHg before ribavirin treatment showed a more than 20% reduction in HBPG. Thus, portal hypertension is able to be reduced by HCV eradication. However, we should also pay attention to the report by Mondefar, showing that in the subgroup of patients with pronounced portal hypertension at baseline more than 16 mHg, portal hypertension did not resolve in any patient, and 20% of patients showed an increasing hepatic venous pressure gradient at follow-up. Furthermore, very recently, RANS demonstrated that hepatic venous pressure gradient more than 10 mHg persists 2 years after therapy in about 60% of patients with cirrhosis despite SCB eradication, and baseline HBPG more than 16 mHg and ascites identify patients with persistent clinically significant portal hypertension and risk of decompensation. This shows a real-world observation of 15 decompensated cirrhotic patients infected with SCB who were treated with software in a university hospital. As you see, the liver fibrosis markers like type 4 collagen, M2-BPGI, and FIB4 index are all decreased. However, HBPG does not always regress in high HBPG group before software treatment. So ladies and gentlemen, I'd like to summarize my talk. Stellate cells are principal collagen producing cell and contractile machinery in the liver. The activation is relevant to the increase of sinusoidal vasculature resistance leading to portal hypertension. Regulation of liver fibrosis, cirrhosis occurs when pathogen, for example, HBV and SCB, is controlled or removed. SBR reduces HBPG in SCB-infected cirrhotic patients. However, regulation of pronounced portal hypertension, more than 16 mHg, seems to be difficult even after the eradication of SCB in decompensated cirrhosis. Careful monitoring of, for example, esophageal varicose status is definitely necessary in these patients. So these are my colleagues in Osaka City University. Thank you very much for your attention. Thank you.
Good morning. I'd like to share with you a new approach of ultrasound imaging called ultra-fast ultrasound imaging. This is really a key enabler to assess the diagnostic and evaluation of chronic liver diseases. But before getting into the clinical domain, let's recap a little bit from a technical standpoint what ultra-fast ultrasound imaging is all about. On the left side here, you have what conventional ultrasound imaging is, and an image is formed by the successive transmit and receive of multiple lines of ultrasound. While in the case of ultra-fast, we send a plane wave, and the data reflected arrives back at the transducer, being stored in memory, and doing parallel processing, the image is being constructed. As you can see on the left, one needs 128 to 512 transmit to get a full image, while on the right, a single transmit enables you to build a full image, therefore much faster. And as a matter of fact, in our situation, we can acquire the data up to 20,000 frames per second. This enables us to create new mode of imaging like real-time shear wave elastography, the capability to assess tissue stiffness, the ultra-fast Doppler, the capability to measure Doppler flow at 400 Hertz, what conventionally ultrasound delivers that only at 20 Hertz. And doing ultra-sensitive Doppler, enabling the capability to visualize very slow flow in very tiny vessel. This function feature is called Angio Plus. And combining all of that together into a single mode called TriView, where one can simultaneously, in real time, visualize the morphological data, B mode, shear wave elastography, stiffness, and color flow imaging, as can be seen in here. Grayscale, elastography, color flow imaging, and we can blend all of that together as well. So how can this be applied? Can it be applied on lots of various organs, but we have focused this technology on the liver. Looking at how to assess stiffness. Stiffness is in fact the Young's modulus. It's a ratio of a stress applied to a piece of material divided by the strain that this material is submitted to. And it's measured in kilopascal. And there are two key coefficients for this, the bulk modulus and the shear modulus. And from a physics standpoint, Young's modulus is nothing else than around 3 times the shear modulus. So in order to assess Young's modulus, one needs to measure the shear modulus. And this is being done by measuring shear wave. In a tissue, shear wave velocity is proportional to the square root of the shear modulus. Shear wave velocity in tissue, the speed is around no more than 10 meters per second, while the conventional longitudinal wave or compressional wave is well known to all of you. It's around 1,500 meters per second. And the displacement in shear wave is perpendicular to the direction of propagation of the wave. So how do we do that? Well, we launch with a transducer using a long pulse. We launch this into the tissue, and this generates a shear wave propagating perpendicular to the direction where the pulse was created. And to measure the speed at which it propagates, then we switch the mode of the transducer, where we launch plain compressional wave at 1,500 meters per second. So this fast wave, 1,500 meters per second, helps measure the slow wave, 10 meters per second. The data is stored in the memory, and as you can see in here, this is a phantom with a stiffer inclusion inside. Now, from a B-mode standpoint, it's difficult to see the difference, but using shear wave elastography, this is a kind of image that is being built. You see that this zone, which is stiffer, in fact, is measured at between 4.5 and 5 kilopascal, which is definitely much stiffer than the surrounding in here, which is green, greenish, yellowish color. So this is how this works. So going back on the liver, as you know, liver diseases, it's really a global problem. It's been rising strongly. More than 700 million people around the world have liver fibrosis. And the most common cause is hepatitis B or C, NASH, or NAFLD, non-alcoholic fatty liver diseases. So it's a key issue. And the challenge in front of us is how can we assess in a non-invasive way the performance in here of fibrosis in the liver. And more than this is one of a liver issue. But as you can see, the continuum of liver diseases going from healthy liver, steatotic liver, NASH, fibrosis, cirrhotic liver, and then the worst case leading to transplantation or liver failure being led by portal hypertension or HCC, hepatocellular carcinoma. This is typically the domain of a radiologist in here, being able to select patient for transplantation, manage and monitor patient. The gastroenterologist's responsibility is really to diagnose the status of a liver, leveraging shear wave elastography and the response of the liver to the shear wave signal. And then the pharma company have a role to play because they are developing molecules and drugs to assess the status of the liver and trying to move to the NASH situation here. This domain of NASH, I would say this is the domain of the hepatologist, being able to evaluate the steatosis liver and to detect inflammation and ballooning. And in the future, we do believe that the generalist should have a tool to do early detection of NAFLD, leading to this chain reaction in here. So at a high level, this is how shear wave elastography works in the liver. The grayscale image is a morphological image as is being shown in those two cases. And in real time, in the region of the liver, one can assess using color coding the stiffness of the liver. This is here in blue, a healthy liver, where the mean stiffness is around 7.3 kilopascal. And this is a stiffness much higher at 19 kilopascal, indicating already some form of fibrosis. And in order to assess the quality of the signal, we have developed a stability index. If greater than 90%, one can be sure that the data acquired and measured is reliable. So lots of papers have been published, more than 200 peer-reviewed publications, looking at the easiness and reliability of shear wave measurement, comparing shear wave to FibroScan or transient elastography, where for different pathologies, orange is shear wave, blue is FibroScan, so it's equivalent or superior to transient elastography. By measuring stiffness in the liver and the spleen, that can be used to rule out portal hypertension, and shear wave elastography measurement could also monitor the patients under treatment. Looking at the stiffness and the Metavir score, the correlation is fairly good, as can be seen in here in that data. Understanding, however, that the speed of a shear wave also depends on its frequency. So the FibroScan measures shear wave at 50 Hertz. In the Explorer, we have a broadband capability where the shear wave is being measured between 40 and 300 Hertz, providing for more accurate assessment of stiffness and alleviating dependence on inflammation and steatosis. So this is comparison of FibroScan versus shear wave elastography with wideband or a simulation around 50 Hertz to show the equivalence of the two methods. Here is comparing FibroScan with shear wave elastography and with RFI. So first observation, we have less outliers in the measurement which have been done and published in 2014 in the Journal of Hepatology, and certainly much better differentiation of each of the stages compared to the other competitive method. And if one look at the area under the ROC curve, looking at Hep B patient, light blue with shear wave and dark blue with transient elastography or FibroScan, we see that we have a bigger area under the curve in the case of shear wave elastography. And similarly for NAFLD patient, again, light blue is shear wave and dark blue is transient elastography, also having better performance. Now, Herman has published in Hepatology in 2017 results on meta-analysis which is done, providing information regarding cutoffs in here for different pathologies, looking at going from Metavir score 1 to 2, 7.1 kilopascal is the threshold value. From 2 to 3, it's around 9 kilopascal. And from 3 to 4, it's between 13 and 12 kilopascal. This is important, those threshold value, because this helps also assessing non-invasively diagnosis of portal hypertension, as is being shown here in this slide in cirrhotic patient. But same thing, a prospective multi-center study published by Jensen in Liver International in 2017 has measured liver shear wave elastography horizontal axis versus spleen shear wave elastography, and highlighting here in the diagram the clinically significant portal hypertension, CSPH, likeliness in here in the data set that has been acquired. All of that has been supported by international guidelines. One of them presented in here is the World Federation of Ultrasound in Medicine guidelines defining the basic principle, the terminology, and results related to breast and results related to elastography. Similarly, the EFS-UMB, the European Federation Society of Ultrasound in Medicine and Biology, has developed similar guidelines. Now, what's quite interesting, the interest has also shifted to the assessment of new tools or potentially new biomarker to assess liver function, measuring attenuation of the ultrasound signal, helping in the assessment of steatosis, measuring the speed of sound of the ultrasound signal and its changes, also helping in steatosis assessment. And then finally, measuring viscosity, looking at the changes in shear wave velocity as it propagates for different frequencies, being able to assess the viscous properties of the liver. Now, why can we do that with shear wave elastography? Well, as already mentioned earlier, the bandwidth of shear wave is much higher than the bandwidth of a fibroscan, which is centered around 50 hertz, and strain elastography, it's 0 hertz. So this approach to wideband opens the door to evaluate dispersion of the signal, which leads to the evaluation of this new parameter, viscosity. And this is highlighted in here. You look here at shear wave speed for different viscous material, as can be seen in here. This light blue is totally non-viscous material. And as you can see, the shear wave velocity doesn't change with frequency of a shear wave signal. Now, if you take this purple one, which is highly viscous, as you can see, there are significant differences between shear wave elastography measured at 100 hertz and shear wave elastography measured at 350 hertz. And the slope of that measurement gives you the viscosity of a medium. You can see that in this short movie. This is shear wave speed measured at low frequency, and this is shear wave speed measured at higher frequencies. You see the speed is quite different. Now, this viscosity can be acquired in real time with fibrosis and displayed on the same image at the same time of the information related to fibrosis in real time as well. So we can build those qualitative and quantitative maps measured in Pascal second, which is the indication of viscosity. So again, if you look at the clinical need, the radiologist will still be a key player in that domain. Gastroenterologists here, the pathologists in that field in here, and the dream is to be able to provide in the future a simple tool for the general practitioner that could assess steatosis or the premise of steatosis or fat liver as soon as possible. All of those measurements, all of those clinical trials have led to measurement of attenuation and what is the normal value for healthy patient. The higher the attenuation, the higher the liver fat content. Same thing for the sound speed. The lower the sound speed value, the higher the liver fat content. Viscosity, the higher the viscosity value, the higher the liver inflammation level. And in the case of elasticity, the higher the stiffness value, the higher the liver fibrosis stage. So this opens the door to a new set of parameters to improve the diagnostic efficacy of a physician. As a conclusion, ultra-fast ultrasound imaging is really at the cross-section of multiple domain or application. The only one I talked about this morning and its impact on shear wave elastography, but we have similar experience with impact on ultra-fast Doppler. Blending optics and acoustic leads to a field of photoacoustic, and ultra-fast plays a role in here. Looking at microbubble and ultra-fast contrast could lead to real-time molecular imaging. And finally, a domain which has lots of future is functional ultrasound, being able to image brain activity and becoming a versatile imaging tool in neuroscience. Thank you for your attention.
Dear Professor Xiaolong Qi, Chairman, ladies and gentlemen, it's a great pleasure for me to give a speech in APASL Single Topic Congress 2020 Guangzhou. Also, I would like to congratulate Professor Qi and his team to organize this very important meeting in this challenging period of pandemic. Today, I am going to speak about ultrasonic assessment for the diagnosis of portal hypertension. Portal hypertension is a common clinical syndrome characterized by an increase in portal venous pressure. There are invasive and non-invasive methods for the diagnosis of portal hypertension. Gold standard methods for assessing portal hypertension include the measurement of hepatic venous pressure gradient, endoscopy, CT, and MR angiography. But there are invasive, expensive, and not available at all centers. Therefore, non-invasive alternatives have been the subject of extensive investigation. The measurement of hepatic venous pressure gradient is considered as a safe and reliable procedure indirectly to individuate the portal pressure and monitor the portal hypertension. Hepatic venous pressure gradient value above 5 millimeter mercury is suggestive of portal hypertension. Hepatic venous pressure gradient is a surrogate for the portosystemic pressure gradient. Clinically significant portal hypertension is defined as a gradient greater than 10 millimeter mercury, and variceal bleeding may occur at a gradient greater than 12 millimeter mercury. Ultrasound is the first-line imaging examination to be performed for the diagnosis of portal hypertension. Ultrasound is safe, repeatable, inexpensive, and highly sensitive in detecting thrombosis in the portal vein and hepatic vein. But intestinal gas and obesity limit the examination. Ultrasound easily shows changes in liver morphology and signs of portal hypertension. It's necessary to have an advanced training and comprehensive knowledge for optimal usage of ultrasound for the diagnosis of portal hypertension also. There are two signs which are 100% pathognomonic for the diagnosis of portal hypertension. The first one, portosystemic collaterals, such as paraumbilical vein, splenorenal collaterals, coronary vein, and others. And the second sign is reversal of flow in the portal vein system. Splenomegaly is commonly associated with portal hypertension, but is not specific. Also, portal vein dilatation higher than 13 millimeter in diameter, ascites, and occluded hepatic veins are less pathognomonic signs of portal hypertension shown by ultrasound. B-mode ultrasound provides fundamental tissue images measuring vessel diameter and spleen size to identify the ascites and demonstrating abnormal collateral route. I always remember my mentor, Professor Kunio Okuda's words. Ultrasound is like a stethoscope for the gastroenterologist and will be so in the future also, emphasizing the promising future of ultrasound. And now, ultrasound became a must diagnostic method for all patients' examination. One of the earliest studies for the ultrasound diagnosis of portal hypertension, titled Collateral Veins in Portal Hypertension, Demonstration by Sonography, published at American Journal of Röntgenology in 1981. In this study, diagnostic value of real-time sonography for portal hypertension was evaluated in 38 patients with collateral veins using a linear array scanner in comparison with percutaneous transhepatic portography. We demonstrated that the frequency of detection of collateral by sonography relative to that by percutaneous transhepatic portography was 85% for the coronary, 100% for the umbilical vein, and 10% for the short gastric veins. We conclude that ultrasound is perhaps the first choice procedure for the demonstration of collateral veins and diagnosis of portal hypertension. Recent developments in digital technology have introduced various imaging modes, color power Doppler, harmonic imaging for contrast enhancement, three-dimensional visualization, and fusion imaging. Doppler ultrasound, with the advantage of real-time observation of blood flow, evaluates the severity of liver disease and portal hypertension. Doppler ultrasound evaluates the patency of portal vein system and reverse portal flow. And also, Doppler ultrasound can be used follow up the patency of translocular intrahepatic portosystemic shunt and proved useful to save unnecessarily invasive hemodynamic procedures. Portal hemodynamic are predictive markers of outcomes in cirrhosis. Lower velocity, less than 12.8 centimeters in the portal vein trunk, in compensated cirrhosis for decompensation, and reverse portal flow in demonstrated cirrhosis for poor prognosis. Also, it provides presentation of the velocity by color scale, but the effects of the Doppler ultrasound to predict the severity of portal hypertension may still be debated due to the lack of definitive parameters. Robinson and his colleagues pointed out that coronary vein can be demonstrated the most prevalent and clinically important by Doppler ultrasound. Also, they detected flow directed away from left portal vein through umbilical vein, indicating of the recanalization. Endosonography is not non-invasive procedure, but may help the diagnosis of portal hypertension, demonstrating esophageal varices, dilatation of short gastric veins, and other collaterals. Also, two major diagnostic applications of endoscopic ultrasound-guided interventions include angiography and assessment of intravascular pressure. Contrast-enhanced ultrasound is applied to differentiate diffuse liver disease and assess the severity of portal hypertension. Recent studies show the diagnostic abilities of contrast parameters based on dynamic microbubbles for portal hypertension. Contrast-enhanced ultrasound provides analysis of transit time of microbubble contrast agent through the liver. It was demonstrated that decrease in the transit time between the hepatic vein and the hepatic artery or portal vein is related to the degree of portal hypertension. Subharmonic imaging is a novel technique using a characteristic property of microbubble. There is a good overall agreement between the subharmonic aided pressure estimation gradient and hepatic vein pressure gradient. Eisenberry and his colleagues reported that the diagnostic abilities of the subharmonic aided pressure estimation gradient were 89% sensitivity and 88% specificity for the patients with clinically significant portal hypertension. Since the primary cause of portal hypertension is the mechanical increase in intrahepatic resistance due to fibrosis and distortion of liver architecture, it's reasonable to assume that non-invasive parameters of liver fibrosis may indicate the presence of portal hypertension. So, as the principle of elastography, it is non-invasive medical imaging technique that helps to determine the stiffness of organs most commonly used for liver. Transient elastography is a novel, non-invasive, safe, and easy to perform technique that gives information on the level of fibrosis by measuring liver stiffness through the transmission of mechanical waves into the liver tissue and after analysis of the wave propagation and liver tissue deformation. Liver fibrosis is the first and main determinant both of tissue stiffness and of the intrahepatic resistance to portal blood flow. Obesity, presence of ascites, and increase of the ALT value are all limiting factors that may impede a precise measurement of liver stiffness. Liver stiffness reveals the grade of portal hypertension and thus predicts the presence of varices. A strong correlation comparing liver stiffness and in diagnosing portal hypertension was found when hepatic venous pressure gradient was below 10 mm mercury. But there is a meta-analysis from 18 studies showed the utility of transient elastography for detecting significant portal hypertension. There are some studies demonstrated that transient elastography is very good predictor method for the assessment of portal hypertension. Acoustic radiation force impulse elastography with any B-mode liver ultrasound scan gives a detailed and reliable information on the severity of liver fibrosis. The mean shear wave velocity measurements in the liver and the spleen demonstrated a good correlation with the portal vein pressure measured with hepatic venous pressure gradient. However, spleen elastography is inferior to liver elastography for the detection of portal hypertension. It was asserted that shear wave elastography is better than transient elastography, showing the liver and spleen stiffness. Moreover, shear wave elastography more successful than transient elastography technically. There is no data using two-dimensional shear wave elastography and strain elastography for the diagnosis of portal hypertension. By using MR elastography, a higher spleen stiffness and strong correlations between hepatic and splenic stiffness were demonstrated in patients with cirrhosis. According to current data, we can say that MR elastography in detecting portal hypertension is a promising method but needs further studies. In this busy slide, it was shown that almost all diagnostic methods using or including somehow ultrasound waves have significantly higher accuracy rates with high sensitivity and specificity values for the assessment of portal hypertension. As a conclusion, ultrasound imaging very useful, non-expensive, safe, repeatable, and first-line imaging examination to assess for the diagnosis of portal hypertension. The Doppler technique offers real-time observation of blood flow with qualitative and quantitative assessments, and the application of microbubble-based contrast agents has improved the detectability of peripheral blood flow. Different techniques of elastography for the liver and spleen covers a wider field beyond the original purpose of fibrosis assessment. Developments of ultrasound technology enhance the practical use of ultrasound in the assessment for the diagnosis of portal hypertension. Thank you very much for your attention.
Hi, I'm Rafael Ximenes from University of São Paulo, Brazil. I'm a member of the steering committee of the Portal Hypertension Special Interest Group from ASLD, and I'm also the founder of BLAST Group, the Brazilian Portal Hypertension Diagnosis and Monitoring Study Group. I will talk to you about new definitions of AKI and hepatorenal syndrome in patients with cirrhosis. Our agenda, we will talk about AKI definitions, especially AKI in cirrhosis, the spectrum of renal dysfunction, and hepatorenal syndrome itself. Well, acute kidney injury, or AKI, is defined by a worsening of renal function within hours or few days. The consequences of this renal dysfunction are hypervolemia, metabolic acidosis, hyperkalemia, in the more severe case, neurologic dysfunction, also coagulopathy, and for all those reasons, an increase in mortality. Acute kidney injury may have many different etiologies. Some of them are considered pre-renal, which are hypovolemia, decrease in cardiac output, and also vasodilatation, in which we will have a decrease in the effective circulating volume. We can also have AKI from renal etiology, like tubular injury, glomerular disease, and also interstitial disease. And less frequently, post-renal AKI, secondary to retrorectal obstruction, or bilateral rectal obstruction. In patients with cirrhosis, we have a high incidence of AKI. About 20 up to 60% of patients with cirrhosis will have AKI during an hospital admission. The reasons for that are many, especially the higher risk of bacterial infections, variceal bleeding, the use of diuretics and other nephrotoxic drugs, and hypotension, which are all common in patients with cirrhosis. How can we diagnose AKI? We can use the serum creatinine, not the absolute value, but an increase in creatinine of at least 0.3 in up to 48 hours, an increase of 50% from baseline occurring in up to 7 days, in which the baseline is the most recent value, stable one, in the past 3 months. Or if we don't have a baseline, we can use the one from hospital admission as baseline. And finally, we can define AKI by urinary output below 0.5 milliliters per kilogram per hour for more than 6 hours. In this case, the patient has to be using a bladder catheter so that the measure may be reliable. AKI may be staged in stage 1, in which the creatinine is up to 2 times the baseline value. Stage 2, creatinine between 2 and 3 times up from the baseline value. Or stage 3, in which we have an increase over 3 times the baseline, or a final creatinine value of 4 or more with an acute increase of at least 0.3, or the need of renal replacement therapy. The severity of the disease increases when we increase the stage. So patients with stage 1 have a mortality of 29%, patients from stage 2, 43%, and patients from stage 3, 52% of in-hospital mortality. These data are from my PhD thesis and are similar to others published by our other groups. The other important factor is the progression of AKI to higher stages. If that occurs, the prognosis is much worse. So patients with AKI without progression has an in-hospital mortality of 10%, and in those which the AKI progresses, the mortality increases to 83%. These are also data from my PhD thesis. AKI is one of the stages or one of the phases of the spectrum of renal dysfunction. We also have acute kidney disease, in which we don't have criteria for AKI, but we don't have chronic kidney disease as well. And we also have chronic kidney disease, in which the glomerular filtration rate is above 60 for more than 3 months. These are not mutual exclusive, so we can have a patient with AKI and also with chronic kidney disease. And these two diseases are very related. Today, we know that patients with AKI may not recover from it. So 25 to 33% of them will develop chronic kidney disease. On the other hand, patients with chronic kidney disease have a higher incidence of acute kidney injury. So chronic kidney disease is considered a risk factor for AKI. Let's talk about hepatorenal syndrome. Well, hepatorenal syndrome is a renal dysfunction specific of patients with liver disease, especially patients with cirrhosis. They should have a site so that we can think about hepatorenal syndrome. We will understand that further. The HRS hepatorenal syndrome is caused by some hemodynamic dysfunction, which is typical from these patients with advanced cirrhosis, and that leads to renal hypoperfusion. And unfortunately, these patients have a very dismal prognosis. Which is the pathophysiology of HRS? The first thing is portal hypertension, leading to splanchnic vasodilatation, which leads to decreased effective circulating volume. That will result in the activation of vasoconstrictor systems, and these vasoconstrictor systems, especially the aldosterone renin-angiotensin system, will lead the kidneys to reabsorb more water and sodium. As this process gets worse, the activation of the vasoconstrictor systems will be so intense that we will start to have renal artery vasoconstriction, and so kidney hypoperfusion, leading to a worse renal function. This is not the only mechanism that acts in HRS. Nowadays, we know that the inflammation is a very important component of this pathophysiology. The inflammation plays a role in the renal hypoperfusion. It leads to hemodynamic dysfunction, but it always leads to tubular injury and also microcirculating dysfunction in the kidneys and also in other organs. HRS may be classified as HRS-AKI, formerly known as type 1 hepatorenal syndrome, HRS type acute kidney disease, and also HRS chronic kidney disease, formerly known as HRS type 2. The diagnostic criteria of HRS were reviewed last year, and they are cirrhosis, acute kidney failure, or acute on chronic liver failure with ascites. They had to fulfill AKI diagnostic criteria as previously mentioned, no response to diuretics withdrawal and infusion of albumin 1 gram per kilogram per day for at least 2 days, absence of shock, and no current or recent treatment with nephrotoxic drugs. The other criteria are absence of parenchymal kidney disease and suggestion of renal vasoconstriction with sodium excretion fraction below 0.2, and it would be much more specific if it is below 0.1%. Parenchymal kidney disease is defined by proteinuria over 500 milligrams per day, more than 50 red blood cells per high power field, increase in urinary injury biomarkers if they are available, and abnormal renal ultrasonography. Here we have to mention that if the patient has a known chronic kidney disease, this absence of parenchymal kidney disease may not be present, and that will not exclude the possibility of HRS diagnosis. Just to mention one of the urinary injury biomarkers, NGAL, which is one of the most used ones, the most studied ones, and it really shows that the etiology, according to the etiology of acute kidney injury, the levels of NGAL are different. But you can see in this slide that the range is very wide, and I believe it's not ready for use yet. How can we treat HRS? First, we have to identify and treat the triggering factor if it is present. We have to withdraw drugs that worsen hemodynamic dysfunction, especially beta blockers and nephrotoxic drugs, and administer albumin with a vasoconstrictor. The drug of choice is terlipressin. This treatment is associated with a higher chance of HRS reversal, a higher survival, but unfortunately is also associated with high costs and a high adverse events rate. Albumin is administered as 1 gram per kilogram in the first day and then 20 to 40 grams in the other days. It's responsible for volume replacement and also improvement in hemodynamic dysfunction. And nowadays we know that it also have anti-inflammatory effects. Terlipressin, which is a vasoconstrictor, the dose of use is from 2 to 12 milligrams per day. We have to evaluate response every 2 or 3 days, and we expect that the creatinine will drop of at least 25%. If that does not happen, we try to increase the dose. We also have to monitor for adverse events occurrence, especially hypervolemia, arrhythmias, and also ischemic events, which unfortunately are common when we use terlipressin. Terlipressin can be used both as a bolus or as continuous infusion, but we know that under continuous infusion, it has the same efficacy than bolus, but with a lower rate of adverse events. So nowadays, that would probably be the preferred way to administer it. Noradrenaline is an alternative, especially in places where terlipressin is not available. In earlier studies, they demonstrated that it has the same efficacy with lower adverse events rate. However, more recent studies in patients with ACLF showed that noradrenaline had a lower rate of HRS reversal, 16% against 40% using terlipressin, and also a lower 28-day survival, 20% against 48%. So terlipressin is still the drug of choice. The treatment duration is up to 14 days, or when HRS reversal occurs, that means the creatinine return to within 0.3 from the baseline value, or if serious adverse events occurs that we need to withdraw the treatment. Unfortunately, the prognosis of HRS is very poor. Here we see a survival curve where we can see that in 3 months, less than 10% of patients are still alive. In fact, the median survival of patients with HRS type AKI is only of 2 weeks. So in non-responders, we have to think about the prognosis. If it's a transplant candidate, maybe we'll start dialysis as a bridge to transplantation, or if not, we have to consider the possibility of palliative care. Thank you for your attention.
Greetings from the Institute of Liver and Biliary Sciences. I am extremely thankful to Professor Xiaolong Qi, President of the APASL Single Theme Conference 2020 at Guangzhou, for giving me this opportunity to speak on the role of beta blockers in acute and chronic liver failure. This will be the outline of my talk. We will first discuss the APASL definition which we use, HVPG in ACLF versus cirrhosis, HVPG as a predictor of mortality, variceal size and the risk of bleed, and role of non-selective beta blockers in ACLF, what were the clinical studies, and what could be the possible mechanisms of beneficial effects of beta blockers in acute and chronic liver failure. We use the APASL definition, which is like ACLF is an acute hepatic insult manifesting as jaundice and coagulopathy complicated within 4 weeks by clinical ascites and or encephalopathy in patients with previously diagnosed or undiagnosed chronic liver disease or cirrhosis, and there is a high 28-day mortality. If we look, this is our data in which we studied 48 patients in 3 groups, ACLF, compensated cirrhosis, and decompensated cirrhosis. And as we can see in the ACLF group, large varices were found in 30%, small varices in 70% of the patients. Now, if we see the HVPG levels in the 3 groups, we can see that ACLF patients with large varices had comparable HVPG as the decompensated cirrhotic patients, whereas ACLF patients with small varices had comparable HVPG levels as compared to the compensated cirrhosis patients. Now, HVPG as a predictor of mortality in ACLF. This was again our data, 57 ACLF patients, follow-up of 3 months, 47% dead within 3 months, 24 repeat HVPGs at 3 months. And if we see, as compared to alive patients versus dead patients, HVPG was 15 in alive patients, whereas 21 in dead patients. And on multivariate analysis of the baseline predictors, HVPG and presence of encephalopathy were significant predictors of mortality. What is the relationship between variceal size and the risk of bleed? In this study, 57 ACLF patients, the median grade of varices was 2, 26 died. 6 patients developed variceal bleed during follow-up. All 6 had at baseline small varices, but at bleed, they had progressed to a median grade of grade 2. That means progression of the varices can also occur in the ACLF setting. What are the clinical studies of non-selective beta blockers in ACLF? There are not many studies. This is the retrospective data from the canonic study in which 349 patients with ACLF were recruited, 227 had ACLF at inclusion, 72 had ACLF post-inclusion, and overall if we see 164 patients were on non-selective beta blockers and 185 patients were not on non-selective beta blockers. And as we can see, patients on non-selective beta blockers had less severe ACLF, 185 patients with non-selective beta blockers and 164 patients with non-selective beta blockers. ACLF grade 3 much higher among patients with not using non-selective beta blockers, and the mortality also higher in such patients who were not on non-selective beta blockers. Similarly, patients on non-selective beta blockers have less ACLF progression at 1 week. As we can see in this graph, this bar shows patients on beta blockers. 1 grade reduction was in a higher percentage of patients who were on beta blockers, and 1 grade increase was in less percentage of patients who were on beta blockers as compared to patients who were not on beta blockers. Now, patients who discontinued non-selective beta blockers after their ACLF diagnosis have higher mortality. In the same study, 78 patients were discontinued non-selective beta blockers after they developed ACLF, and 77 patients continued with their non-selective beta blockers. And as we can see, patients who continued with their beta blockers had lower 28-day mortality, and also the grade of ACLF was less in them. And even 90-day mortality was significantly less in patients who were continued on non-selective beta blockers after they developed acute or chronic liver failure. This was a randomized control study from our group in which ACLF as per the APASL criteria were screened 280 patients. HVPG was measured in 150, and ultimately 136 patients were randomized, 66 into the carvedilol group and 70 into the placebo group. And as a whole, we can see that this trial was on no or small varices patients with HVPG of more than equal to 12 mm of Hg. If we see the baseline characteristics, then both the groups were comparable, and majority of the patients, the etiology of ACLF was alcoholic hepatitis, and second most common was chronic hepatitis B and reactivation of hepatitis B. HVPG was comparable in both the groups, 19.5 and 18 respectively. If we see the Kaplan-Meier curve for survival in both groups at group 20, carvedilol patients had significantly better survival as compared to the placebo group with a long-rank P test of 0.032. But if we say see the 90-day survival, this is the 28-day survival, but by 90 days the survival benefit is gone, and there is no significant difference between the carvedilol versus placebo group as far as the survival is concerned. Similarly, we can see that less patients on the carvedilol had worsening of ACLS severity up to 2 weeks from the start of treatment. As we can see, this colored bar shows the carvedilol group, and in the carvedilol group, 1 grade increase was seen in 3% as compared to 20% in the placebo group, which was statistically significant. Similarly, if we compare both the groups, then we can see that mortality within 28 days was much less in carvedilol group. AKI development within 28 days was much less in the carvedilol group as compared to placebo, whereas variceal bleed development was not different. Also in the carvedilol group, development of any infection within 28 days was significantly less as compared to the placebo group. As among the infections, SBP was much more decreased in the carvedilol group as compared to the placebo group, whereas other infections were not statistically significantly reduced, except pneumonia development, which showed a trend towards significance, but actually p-value was not significant. We did repeat HVPG among patients who did not bleed and survived with native liver. And as we can see, among the carvedilol group as compared to the placebo group, the percentage change in HVPG from baseline, HVPG decreased more than 10% and HVPG decreased more than 20% at the end of study was significantly more achieved in more number of patients in the carvedilol group. Similarly, variceal progression at the end of study was also less in carvedilol group as compared to the placebo group. So what could be the possible mechanisms of beneficial effects of non-selective beta blockers? The hemodynamic effects of non-selective beta blockers are well known. Immunomodulatory effects are possible, and there is evidence of reduced bacterial translocation on beta blockers. This was a meta-analysis which showed that beta blockers protect against SBP in cirrhotic patients, and the number needed to treat to prevent one additional episode of SBP was 8 with a range of 5 to 18. Now, what is the threshold of HVPG reduction considered protective for SBP development in cirrhotics? More than 20% reduction is a well-known figure for protection against variceal bleeding, but for predicting absence of risk of SBP, only 11% reduction is needed. That means that non-selective beta blockers are protective against infection in a larger group of patients than it is protective against bleeding. So what could be the possible mechanisms? As we can see, beta blockers lead to reduction in the splanchnic blood flow, which leads to decreased intestinal mucosal edema, decreased intestinal congestion, decreased bacterial translocation, and decreased SBP. Beta blockers also lead to increase in intestinal transit, which again leads to decreased bacterial translocation and decrease in SBP. Beta blockers also inhibit stress-related cyclic AMP kinase A pathway, which enhances the immune response and antibacterial responses, which again leads to decrease in SBP. So to conclude, ladies and gentlemen, non-selective beta blockers have both hemodynamic and non-hemodynamic effects. Increased portal pressure in ACLF contributes to complications and organ failures in ACLF. Non-selective beta blockers may have beneficial effects in ACLF patients over and above its hemodynamic effects. In ACLF patients with either no or small varices and high HVPG, carvedilol leads to improved 28-day survival, less development of AKI and SBP up to 28 days. The benefit is for short term only. In the long term, the benefit seems to go away. ACLF patients already on non-selective beta blockers should be continued if there are no contraindications, and ACLF develops. ACLF patients who are not on non-selective beta blockers should be started on non-selective beta blockers if there are no contraindications, irrespective of the varicose status. Thank you very much for your kind attention.
I'd like to start by thanking the organizers for this invitation to talk on the progress in imaging technologies for the non-invasive assessment of portal hypertension and its complications. I'm Michael Pavlidis. I'm based at the Oxford Center for Clinical Magnetic Resonance Research at the University of Oxford. And these are my disclosures. I'd like to start by a quick reminder on the hepatic vein pressure gradient, which, as you know, is a technique that involves the passage of a balloon catheter through the jugular vein down to the right atrium and to the IVC and hepatic vein, where measurements are taken with the balloon inflated to measure the wedged hepatic vein pressure and the balloon deflated to measure the free hepatic vein pressure, with HVPG being the difference between those two measurements. And just some quick reminders of numbers of HVPG being less than 5 as normal, whereas when the HVPG is more than or equal to 10, this signifies clinically significant portal hypertension. This is known now for a while that is an important measurement, as it predicts mortality, variceal bleeding, and decompensation in patients with cirrhosis, but also is useful for identifying those who would benefit from treatment of non-selective beta blockers, but also monitoring the response to non-selective beta blockers. But as we said, this is an invasive technique, and as a result, it requires a lot of skill and expertise to perform, and is therefore not widely available. And there's an interest recently to develop non-invasive alternatives, with an explosion of techniques in looking into this. And there are liver-related markers, primarily liver stiffness, that can be measured with a variety of techniques, or spleen-related markers like spleen size and platelet count, it's surrogate, but also spleen stiffness, or combinations of the two, like the LSPS index that includes liver stiffness, spleen diameter, and platelet count. And there's also a lot of interest that has developed in using cross-sectional imaging techniques using CT or MRI with or without contrast to assess hepatic vein pressure gradient. And there's a variety of techniques that have been used, and this is going to form the focus of the rest of my talk, which the imaging techniques in their entirety, I would say, probably represent a minority of the techniques that have been examined in this area. I'll start by talking about the techniques we've been using, and we've been using T1 and T2 star relaxometry using MRI. And I'll start by introducing this concept of the ion-corrected T1, which we've looked at in the liver. And as you know, T1 is a measure of relaxation time in the liver, which is a inherent property of tissues. And you can see here 2 patients. You can use these mapping techniques to measure T1, and the top patient and the bottom patient have very similar looking livers with this mapping technique, but also when you measure the T1 relaxation time, those are very similar. However, T1 relaxation time is influenced by how much ion there is around, and you can use T2 star to measure ion. And in the case of the top patient, the T1 relaxation time is long, indicating low ion, whereas in the bottom patient, the T1 relaxation time is short, indicating high ion. And when you take the ion into account and you correct
the T1 for the presence of iron, then you can see that you get different results for the T1 that would have been measured in a physiological amount of iron. So in the top case, the T1 drops a little, but in the bottom case, the T1 increases quite a lot. And we have shown that application of this correction algorithm improves association of liver T1 with liver fibrosis. So when we started being interested in portal hypertension, we wanted to look at this metric on the spleen. And these are some examples of what the spleen looks like with this mapping technique. Again, in the top, you can see a patient with quite a deep purple spleen corresponding to a T1 of about 1500 or just under, whereas at the bottom you see a spleen with which is reddish corresponding to a lower T1 value on the color scale. And we've looked at it in 19 patients and found this measure to be correlate quite well with the hepatic vein pressure gradient, and it had good diagnostic accuracy, which was in fact better than the liver. But this is a small study of only 19 patients, so we can't really read very much into it beyond it being a pilot study. We're also interested to look at how spleen MRI could be used for the assessment of esophageal varices. And again, as you know, guidelines would recommend that patients with chronic liver disease are screened for esophageal varices with upper GI endoscopy every 2 or 3 years. But if all patients with liver cirrhosis have endoscopy, it's only a minority, as low as 5% that would have varices needing treatment. So a lot of patients are undergoing endoscopies unnecessarily. And this is something that is being addressed, and the Baveno has introduced this criteria where they advise that if a patient has platelet count more than 150 and liver stiffness less than 20, then endoscopy can be avoided. And these measures can avoid up to a third of endoscopies, but still leave a high proportion of patients having endoscopies unnecessarily. So there is a need to avoid more endoscopies while missing not very many varices needing treatment. So this is what we did in our second study, where we looked at firstly the diagnostic accuracy of spleen parameters for varices needing treatment. So this is looking at the positive predictive value of the measurements. We looked at the variety of spleen parameters, but the one that performed best was the product of spleen T1 and spleen diameter, which had an OROC of 0.87 and sensitivity and specificity of around 80%, which again is quite good. We also looked at parameters that could be used to exclude varices needing treatment akin to the Baveno criteria. And we found that spleen T1 less than 1307 milliseconds or spleen diameter less than 137 millimeters could be used to exclude patients for endoscopy, and this avoided 2/3 of endoscopy, and only 20% of patients had endoscopy unnecessarily. Again, as in previous cohorts, the prevalence of varices needing treatment in our cohort was only 14%. And what was perhaps also interesting in this study is that this new criteria performed much better than previously published criteria like the Baveno or expanded Baveno criteria or the LSPS metric that we've seen before. So again, promising, but this can only be considered as a training cohort, so validation is needed. But what about other techniques that other people have looked at? And there are techniques looking at vascular flow. This is a a study from Nottingham, again in the UK. And here they've looked at velocity of blood flow in the superior mesenteric artery, the splenic artery, and also flow in the azygous vein. And again, you see that these individual flow measures correlate well with HVPG. And what they've done in this study is they've looked at a multivariate model where they've done univariate and then multivariate analysis to identify the independent variables for predicting HVPG, and they've identified liver T1 and splenic artery velocity as the two measures that are independent in this multivariate model. And what they've shown is that, again, in an original cohort and a validation cohort, that the predicted HVPG using this model is not different from the measured HVPG. Again, showing promise as a technique that could be used to measure HVPG. Other techniques that have been used include the quantification of liver surface nodularity. This is a study from France where they look at liver surface nodularity, and I think you can see this better in the magnified insert here, where the red line is the average position of the liver capsule, and the green line indicates the nodularity. And the more the green deviates from the red, the more nodular the liver is. And perhaps you can see that in the case of the bottom patient, there is more deviation from the average. And again, the bottom patient has clinically significant portal hypertension, the top patient not. And again, they look at the association with HVPG and this quantification of liver stiffness nodularity with good associations. And here they propose a rule-in and rule-out cutoff, where those above the rule-in cutoff can be diagnosed with clinically significant portal hypertension based on this measurement. Those below the rule-out can be diagnosed with clinically significant portal hypertension without CSPH, whereas those in the middle may still require HVPG, but again, the number of patients needing HVPG would be much less. And there have been some more artificial intelligence type techniques, including radiomics, which have been examined. This is a study from China, which looked at radiomics from CT imaging. And radiomics involves the evaluation of a set of predefined imaging characteristics, which can be based on texture or non-texture. And you can see here some of these characteristics that are examined in this model, including volume, size, solidity, and eccentricity. And again, here the comparison of this radiomics HVPG with other measures, showing that it performs better compared to things like FibroScan or APRI and FIB4, for example. And even more recently, the same group have looked at convoluted neural networks. Again, this is a way of applying artificial intelligence to images. This is a less supervised approach to radiomics. And here it can be applied to CT images or MRI images. And again, training, validation, and test cohorts show very high diagnostic accuracy using these advanced techniques. So a lot of studies have looked at imaging as a way of assessing portal hypertension and using an imaging HVPG, and this has many potential clinical applications, for example, in the workup of patients with HCC, where those with clinically significant portal hypertension may not be suitable for a resection, whereas those without could have a resection. There is stratification of patients for high-risk esophageal varices, where you would apply imaging for selecting those for endoscopy, pretty much in the same manner as the Pavino criteria are applied, or for the selection of patients for treatment with non-selective beta blockers. I have to say that in the imaging field, studies so far have been small or retrospective, and we need more prospective studies addressing specific clinical questions before clinical application of these techniques can be rolled out, I think. And with that, I will leave you with my acknowledgements, and thank you very much for listening.